Today, we're going to be focusing on the topic of hypertension, or high blood pressure. So it's wonderful to have Dr. Jose Rueda with us today. Dr. Rueda has been kind enough to present with us in the past. He's a full-time clinical nephrologist who joined OHSU in 2004 and was the director of the Hypertension Center at OHSU for more than a decade, and now practices at the Portland VA Medical Center since 2022. Let's bring up Dr. Jose Rueda. It's all yours, my friend.
All right. Let's start with mine. So we'll definitely focus this second part of the talk in how to address resistant hypertension. I have 5 cases, and I think we have plenty of time to go through every single one. The first one is going to be the bread and butter workup for somebody with resistant hypertension. Then we mentioned a few of the secondary causes and cases. And case number 5 is a case that I usually tend to present that elicits a lot of responses from the audience and our colleagues of what to do. So just to know where we are and how to communicate with other colleagues, this is our categories of blood pressure here in the United States. So when you tell me I have somebody with stage 2, I know that the blood pressure is greater than 140 over 90. I'll show you a slide in the near future about what the Europeans do on this. So they have a definitely different classification, but I think we're getting closer in crossing the Atlantic in terms of guidelines. There is business for everybody. You see here the prevalence of hypertension in adults is almost 50%. If you were to state that your blood pressure should be less than 130 over 80. One day in 2017, when the guidelines changed, the prevalence was 32% only. So from one day to another one, almost 14% of your people got out of control, and everybody started to panic. This is a point that I make every time I talk about resistant hypertension. I guarantee you that you're not checking the blood pressure like most recent trials are doing it, meaning that they use an automated machine, not included screen trial here, but the blood pressure on that trial would change more to the guidelines in 2017 was done using this automated machine. So you put the patient in the room, you set up your machine, it takes 3 or 4 readings in about 5 minutes and it gives you the average, but no one is inside the room. And there is no MA, there is no tech, no doctor, no nurse, and so forth. We bought these machines in the last job that I had in this hypertension clinic at the university. We pay about $800 for each one, and we tried them, and it really made a big difference. The systolics would drop 10 points, so this issue of glycemic hypertension would actually disappear if you were to do this. The problem is it really adds 10 minutes to your visit. But that will be, these are the blood pressures that the guidelines follow. Automatic blood pressures, nobody at the office with patient. So like I said a few minutes ago, the European just published guidelines 5 months ago. And definitely, if you can see here, they're getting closer to the ones that we follow here. I agree with some of the European guidelines. For example, somebody that is above 80 years of age, I don't think that every single one of those guys should have blood pressure 130 or 80. These guidelines here on the right side are closer to the ones that we follow here at the VA. We're not that aggressive in the elderly population. Also, they decided to include beta blocker as a first line of therapy. Here in the United States, the American Heart Association recommend only adding beta blockers as a step 7 if your heart rate is above 70 or you have a companion patient. So, like Dr. Gustafson suggested, most people would definitely benefit from systolics below 130, especially if they have high cardiovascular risk in 10 years. But a lot of patients may end up just doing fine if they have lower blood pressures into, let's say, below 140 and below 150. So what is resistant hypertension? So when you have somebody on 3 or more meds and your blood pressure is not at goal. And what is a goal? Well, for us here, I mean, a reasonable starting point would be above 140. We don't want that. Let's try to get it below 140. If he tolerates or she tolerates therapy, maybe we can get down to below 130. It's never 120 for us, only nobody. So the classification states that you have to be on a calcium channel blocker, you have to be on a RAS inhibitor, and you have to be on a diuretic. And all agents should be prescribed at maximum or maximally tolerated total daily doses. For example, losartan, the maximum dose is not 25, it's 100. Lisinopril, the maximum dose that we use is 40. Chlorthalidone maybe is 12.5, 25 milligrams, and so forth. Calcium channel blockers, a lot of people want to get it up to 10 milligrams a day, and the same with nifedipine. Also, resistant hypertension could be defined as somebody that the blood pressure is at goal, but is taking 4 meds. And why do we care about resistant hypertension? Well, the outcomes are worse in these patients. And also, there's a high prevalence of secondary causes that you can identify and actually treat those targets and improve their outcomes. And in order to make that diagnosis, what do you have to rule out? Make sure that they're taking their meds and make sure that they don't have white-collar hypertension. And that's sometimes easy and sometimes is very tough to do. So, like I said, if there is 110 million adults over there in the United States, 12 to 15% of them have resistant hypertension. And then we take care of this because we spend a lot of money in treating these patients with heart failure, CKD, and mortality is definitely higher. So we have to do a better job. So the 6 questions that you have to answer when somebody comes to your clinic with resistant hypertension: is it really true? Are we missing a secondary cause? Are they following a dietary low sodium diet? Is volume optimized? Are we using an MRA blocker, a mineralocorticoid receptor antagonist? And if not, why not? And can we use another option that has been shown to be effective in these patients, like amiloride, which is a epithelial sodium channel blocker? And then how we consider referring them to a hypertension center. So I love this slide because this is data from Canada, published many years ago. But they use this automated machine, BP True, that apparently you can find in Canada. It's similar to the other automatic machines that, for example, the Spring trial used. So these are 50 patients that were done that way. They use an automatic machine, no techs, no MAs in the office. The first blood pressure was taken by the physician, and then after that was just the machine. You can see reading number 6, the blood pressure already dropped 20 points by using this machine. And the paper stated that that glycemic response associated with office BP can be eliminated with the use of this automatic machine. And you know, we had a similar experience when we used that automatic machine at the university. So how common is white-collar hypertension in people with resistant hypertension? And I want to point out to this data from De La Sierra in Spain. So they have a huge registry of patients, more than 68,000 patients. And they found out that at that particular point, they wanted a 12% of those people had greater than 140 or 90 blood pressure. So that was the prevalence of resistant hypertension with them. But then they did ambulatory blood pressure on every single one of those people. And guess what? 37.5% of those patients, when the blood pressure was done with this machine, was totally fine. The mean was 122 or 70. So this is one of the things that you can do. If you believe that there is a white coat component, if you have access to a blood pressure machine that can be done in an ambulatory way, do it. Some of them are expensive. The ones that cover your blood pressure for 24/7 But you can just tell patient, hey, check your blood pressure maybe twice a day for 7 days and see we can go to the readings next week. So about 4 out of 10 of the people that you see in your clinic with resistant hypertension might be well controlled at home. This is a great paper that I always show because it was the first time that hypertensive doctors use an assay that you can do in the urine to follow metabolites of blood pressure pills. And they did it in Germany. And this has been done in serum, and it kind of showed the same data. So this is, I think patients referred to a clinic in Frankfurt in Germany with uncontrolled high blood pressure. So they went through the same workup that somebody would do. Okay, let's see, we can maximize the doses and see the blood pressure gets controlled. And out of the 375 patients that they saw originally, 250 got under well control with less than 3 meds. Then they ended up with 108 patients with apparent resistant hypertension. So when you say apparent, you have to, maybe they're not taking their meds, or maybe they have a secondary cause. So they went through that and they ruled out 15 patients with secondary hypertension. So at the end of the day, they ended up with 76 patients, and they didn't tell them that they were checking their urine for metabolites of all these blood pressure pills. It turns out that about maybe 47.5% of these people were just compliant, but a lot of them were not taking any meds. And what it was striking was that 30% of these people, when they were asked, are you taking any of these 4 meds? And they all say, yes, I'm taking all of the 4 that you prescribed. And they had no evidence of these metabolites in the urine. So that's a lot of people out there that might not be doing what you think they're doing. So this is just now in research, in clinical research trial, this is a problem. So it's a must now to do all these assays in the urine and in the blood to see if patients are really taking their meds. So just be aware of that. They're not taking them. They might be lying to you, and they may have white coat hypertension out there. So if you go to that clinic in Frankfurt, it looks like they love beta blockers. That was the medication that they adhere the most compared to ARBs and inhibitors. I'm really lousy at these, and everybody is. It's almost impossible to assess adherence in clinic. So I don't know what you guys do, but what we do here now is we definitely have a great pharmacy program. They call them and they go through the meds. They can be enrolled in a telehealth program that it checks on them often. We try to use 90-day supplies. That definitely that has increased adherence. They don't have to go to the pharmacy every month. And obviously, if you're out there in the world, make sure that you just choose something that is not expensive and long acting. The UK guidelines would tell you to use combo pills. Start with 2 meds. If you need to get up to systolic blood pressure more than 20 points, what are you doing starting with 1 medication? Try to get a combo pill and then start with 2 medications, and I agree with that. All right, so let's start with the first case. 55-year-old man with morbid obesity and long history of hypertension that returns to follow-up. He's on 1, 2, 3, 4, 5, 6 meds and a lot of potassium. Blood pressure is elevated, BMI is elevated, and the heart rate is in the 60s, normal GFR and normal potassium. From the get-go, I would say there is a very small chance that this guy is taking all these meds and the blood pressure is that elevated. So the American Heart Association has these guidelines, so this consensus published a few years ago. So what I just told you a few minutes ago, make sure that the doses are adequate. Make sure that they are an ARB, calcium channel blocker, and a diuretic. Confirm adherence, and that's the tricky part. And then do an ambulatory blood pressure if you have access to that device, or just home beat, please. That's key. After that, you go through the secondary causes. The most common ones that we deal with are obstructive sleep apnea, renal artery stenosis, chronic kidney disease, and primary aldosteronism. The rest of them, I doubt that you're going to ever see one in your lifetime because they're extremely, extremely rare. Pheochromocytoma, Cushing's, chlorthalidone, or the order 7. They also mentioned that you take a look at the back of your retina to see if there is hypertensive retinopathy. If you have somebody with severe hypertension, make sure that they don't have any history of heart disease, if there's LDH on EPD on echo. Check for proteinuria, check for obviously creatinine, and in some patients consider doing an ankle-breaker index to assess peripheral vascular disease. So this is kind of the organigram that we go through on every single one that we see in clinic. So then, like Dr. Gustafson mentioned, we need to, I usually tell them, hey, if you don't lose weight, it's going to be very difficult for us to control your blood pressure. You have to start an exercise program. Even if you walk 30 minutes 5 times a week, is better than doing nothing. If you're taking NSAIDs, we definitely stop those immediately. If you take NSAIDs, at a good dose for 2 weeks, your systolic blood pressure might end up increasing by 15 points. And we ask them to be screened for sleep apnea if they need the screening testing. But I have to say that in our hypertension clinic, every single resistant hypertension that we send for sleep apnea testing, I don't remember one test that was negative. The prevalence is almost 80–90%. The issue is, okay, what if I get treated for my sleep apnea? Do you think my blood pressure is going to be under control? And the answer is no. But you will benefit from decreasing cardiovascular events at 10 years. You might feel better. You might lose weight. And maybe the headaches and the tiredness is going to go away. But this systolic blood pressure response at 6 months with sleep apnea therapy is now the greatest. In most of the meta-analysis, they show that it's about 2.7 to 3 points only. We definitely talk about sodium every single time we see them. This is key. This is like taking another med. And the new kid in the block in terms of dietary interventions is potassium. High potassium diet decreases blood pressure and appears to be related to the fact that if you increase your potassium intake to about 3.5 grams a day, 35 milligrams, you block this channel in the kidney that deals with sodium, the sodium chloride co-transporter. So you start losing more salt. So high K diets that you can achieve with dietary modification can downregulate this NCC channel and give you natural issues. The guidance from the Europeans definitely are all over this potassium business. You got to be careful with using these in somebody with CKD, especially worse than stage 3, because you might become hypervolemic. So optimize those doses, like I mentioned before. Are all RAS blockers created equally? And the answer is no, but you have to start with the cheap one. And the cheap one, it has to be used EID, has the shortest half-life and the less bioavailability, but sometimes you don't have any options. Calcium channel blockers, like I said before, we usually use amlodipine and nifedipine. I don't remember when was the last time I used verapamil, maybe in the 90s. And then we look at diuretics. We want to make sure that they use a long-acting thiazide, like indapamide or chlorthalidone. We rarely use hydrochlorothiazide because it's definitely less potent. And then assess volume status in these patients. And I got to tell you that 70% of the people that show up to your clinic with resistant hypertension, they're usually volume overloaded. You might not find the edema and the gross volume overload, but if you were to do some testing, you find out that these people are retaining salt and water. You can do, obviously on physical exam, you can detect that. You can do renal profiling and see the renal is repressed. You can do bioimpedance testing. We used to have a machine at the university. I got to tell you that it wasn't that reliable, to tell you the truth. And what I just discussed, use chlorthalidone and indapamide in those patients to dilute them. And if the GFR is below 30, consider you do diuretics. All right, so Not all thiazides are created equal. This is a very old paper that shows the difference between a very nice dose of hydrochlorothiazide, 50 milligrams, and chlorthalidone, 25 milligrams. So if you look at these, you gain about 5 points by using a long-acting diuretic in patients with hypertension. The only caveat is that these medications are definitely potent, and there is a maybe 20% risk of hypokalemia, and you have to really check these levels often on these people. I usually don't start at 25, I start at 12.5, and I let them know, hey, I want a potassium done. About a week later, if you have any cramping in your legs, please let me know immediately. And also, I check magnesium levels because these thiazides can induce hypomagnesemia. The third step is you just block the aldosterone receptor. So we have two options so far available in our pharmacies: spironolactone or clarinone. If they don't tolerate any of these two, you can use an ENaC blocker. It's called amiloride, and we use up to 20 milligrams a day of that medication. We usually don't go any higher than that given the side effect profile. And hopefully in the future, we're going to have the availability of two more non-steroidal MRAs maybe in the next 2 to 3 years. They're now doing clinical trials. Spironolactone, I usually say that you got to be careful with this medication because it has a metabolite that lasts more than 30 or 40 hours, and you can give that once a day. But clarinone, the half-life is only 4, so you have to give that BAD, and it has the third potency of spironolactone. And this is one of the reasons why we like to block aldosterone people with resistant hypertension. If you take a resistant hypertension group and you compare aldosterone in plasma and urine, and you do the ratios to aldosterone, the resistant hypertensive patients have definitely higher levels of aldosterone. I'll show you 2 trials that really made changed our practice in the last maybe 20 years. One was the ASCO trial, a European trial that was designed to compare 2 different drugs, a beta blocker and a calcium channel blocker. But if the blood pressure wasn't well controlled, the investigator would allow you to add a medication on a step 7. And one was spironolactone, and the other one was a very potent vasodilator that we don't have it available here in the United States. So they ended up prescribing a Spiro on more than 1,500 patients, and they looked at that data. And the data was impressive. So the blood pressure dropped almost 21 points since they added the Spiro on those patients, and the diastolic also dropped significantly. So since then, the Spiro became kind of the closer you know, if you want to make an analogy on baseball, you bring this pitcher at the end of the 9th inning, and it just closes the game and wins the game for you. So whenever you're thinking about a 4th agent, the Spiro has not been beaten yet. And then it really re-emphasized this issue when the British did this study, the Pathway 2, in 2015, a very well-designed trial. They screened more than 400 patients with resistant hypertension. And what they did was, it was a double-blind trial, crossover trial, and everybody had to be on 3 meds and a maximum doses. And the GFRs were normal, and there were some diabetics in this trial. And every single one of those patients that was divided in these 4 groups went through the placebo, the bisoprolol, the doxycycline, and the spironolactone. So they wanted to compare when you reach that conundrum of somebody on 3 meds, which one is better to add at that point? Spironolactone, doxycycline, bisoprolol, or they just compare that to placebo. So great trial, and we learned a lot. The upper bars are the systolic blood pressures, the lower bars are the diastolic blood pressure. And the spironolactone definitely beat every single one of them. So the way they did it, in every single cycle, they start you at a certain dose of Spiro. In this particular study was 25. And at 6 weeks, if your blood pressure was still out of control, they went up to 50. With the doxycycline, they started 4 and they went up to 8 in the middle of this cycle. And the bisoprolol, which is beta-1 selective beta blocker, They started 5 milligrams at the beginning, and they went up to 10 at 6 weeks. So, and as you can see here, the spiral response was definitely better than every single one. Doxa, bisoprolol, and obviously beat placebo by a lot. So we learned from this trial that spiral is good, safe in those populations, in that particular population. The risk of hyperkalemia was very small, but again, most of these people had normal creatinine, but they were about 20% diabetics. And then, and also what I learned from these guys is doxycycline, when they went up from 4 to 8 milligrams, they only gained 1 point of the systolic. Very disappointing. And doxycycline was as good as bisoprolol. So back to our case. So what did we do first? We went through all these dietary interventions and so forth, and we checked the blood pressure at home. We decided to add spironolactone. We started at 12.5 milligrams a day. We made sure that the nifedipine was extended release. You don't have to make this change the same day. We usually make one change at a time. Next time you see him, you can increase the chlorthalidone to 25 milligrams and follow the potassium closely. Because we started him on a spiral, we usually stop the potassium right away. We really don't like hydrolysis in the patient setting for our patients unless you're pregnant or you have heart failure or something else. So we try to discontinue that. Clonidine, too many side effects. The risk of rebound hypertension is too high, so we try not to use that medication. And Cavedo, we didn't change the dose. Because we added spiral, we decided to cut the lisinopril once a day, given the fact that the combo can increase your risk of hyperkalemia. You went through the screening with sleep apnea, and they usually refer them to sleep apnea clinic, dietitian, and they have to start an exercise program. So when you should be suspicious for secondary hypertension. So all of these should make you think that something is off and you may have you carry a secondary cause. For example, you're 15, you never had any problems with blood pressure, out of nowhere, your blood pressure goes up to 106 systolic. If you're very young and you have systolics in the 140s or higher, if you come to the hospital and you have the diagnosis of malignant hypertension. So what is malignant hypertension? Is when you have papilledema or you have retinal hemorrhages. So they used to have this term in 1918, 1920 to call it malignant because the outcomes of 1 year were as bad as having cancer. So your mortality at 12 months in the 1920s was 80%. It's now the case nowadays, obviously, but it's still high. If you have definitely evidence of sleep apnea or you have severe hypertension in pregnancy, you should consider, do they have fibromuscular dysplasia? Do they have a pheochromocytoma? If you have osteoporosis and obesity, you may consider maybe they have Cushing's. If they have a bruit in the abdominal exam, you may have renal vascular disease, or you're very young with, and a female with an abnormal systolic blood pressure, you can consider fibromuscular dysplasia. Or when you see somebody and the potassium is below 3.5, or is excessive by the amount of diuretic that you're taking, the dose of hydrochlorothiazide is 12.5, and the potassium is 3.2, that's odd. That's odd, and you should consider testing for these secondary causes. What are the most common ones? As I said before, primary aldosteronism is one of the most common ones. Maybe about 20% of our patients with persistent hypertension have that problem. The higher your blood pressure, the higher the prevalence. Renal vascular disease, and if you have a renal artery lesion that is called an increased renin. If you have chronic kidney disease or sleep apnea. So like I said, the prevalence is very high. The rest of them, like I said before, they're very, very rare. But, you know, you have to have you have to know that these cases can present to you, and you have to have a high index of suspicion, and you don't want to miss this because that could be a lethal problem. in these patients. And when to suspect that? Well, if you have somebody with hyperhidrotic spells, diaphoresis, headaches, tremors, palpitations. If you have resistant hypertension, sometimes we discriminate for that. If you have a familial syndrome already that predisposes you for paraganglioma, pheochromocytoma, if you have neurofibromatosis 1 or 1 of course, we're going to test you for that. If somebody in the family has pheochromocytoma, some of these genetic mutations are autosomal dominant, like for example, DHB and so forth. You have to test the relatives. If you get a CAT scan, if you ended up in the ER and they find a mass in one of the adrenals, you should definitely be tested for pheochromocytoma. How do you do that? It's easy. You can do it in the blood or you can do it in the urine. The sensitivity is almost exactly the same. We tend to do plasma-free meds and CATs in our patients. Rotation of the aorta, I've been doing this for about 20 years. I've seen maybe 2 cases, and both of them diagnosed with echoes and one with a chest CT. And in both of those cases, we didn't know that the blood pressure was elevated compared to the lower extremity, so we completely missed it. And one of those cases was in a renal transplant recipient. And the way we figured it out was the renins and the aldosterone were extremely elevated. Believe it or not, that renin profile made the diagnosis, and they ended up getting the echoes and the CTs and so forth. Cushing's, that's another syndrome that is very tricky to diagnose, especially when they don't have this phenotype in which they have central weight gain, round faces, bad deposition in the base of the neck, the muscle weakness, and so forth. In some patients, we definitely we tend to do actually both of these tests sometimes. The sensitivity increases by you adding some of this, but easy to do would be the late night salivary cortisol. We have the salivate, so we give to patients to test that at 11 at night. And sometimes we do the overnight dex suppression test. We give them a tablet of 1 milligram dexamethasone. We tell them to take it at 11, come back the next day and get a replacement with cortisol. So on that particular patient, definitely you should do some workup for secondary causes, at least the kidney ultrasound with renal artery Doppler, and make sure that he doesn't have hyperaldosteronism. Okay, second case. This is definitely a true case that we saw in clinic. Kind of a young guy with a 10-year history of hypertension on 4 meds, and he had already a stroke. Less 59 years old. His blood pressure systolic wasn't that high, but the diastolic was definitely elevated. And look at that potassium of 3.1, which is definitely very low. He was on good doses of atenolol, lisinopril, a diuretic combined with an ENA blocker, tramturan, and a low-dose nifedipine. But the amount of potassium that he was getting was definitely excessive. So this is a guy that meets all the criteria, right? He's on 4 meds, uncontrolled, and hypokalemia. And so you have to definitely jump up and down. This guy really needs workup for secondary causes. So what would be the best screening test for these patients? I would say that you can choose 2 and you'd be right. So we did definitely an aldosterone and plasma reactivity. We wanted for him to get it done in the morning. We want to replete the potassium in some of these cases, because remember that hypokalemia drags your aldosterone down. So it might be your potassium is 3, 4, your aldo is 15. When you get that potassium up to 40 to 4, your aldo might end up being 60, and then you go, wow, we got a problem here. So he got an aldosterone and renin. He got also a kidney ultrasound with Dopplers to figure out if he had a renal vascular disease as well. So we did both at the same time. We have guidance out there that tells you when to suspect primary aldosteronism. The guidelines are old, from 2016, and this is the Endocrine Society really recommending in all of this to check for an aldosterone and renin, especially in the morning. Okay. Do we do a good job? No, based on this report here of more than 146,000 patients with hypertension, it was a retrospective study. The mean age was 65, and they found out that 3.7% had resistant hypertension, and I think the blood pressure was greater than 140 over 90. But doctors only did an aldo testing, a reading testing for primary hypoaldosteronism in 2.1% of patients. So every time I mention this trial, I mention, hey, aldo and reading testing is a little bit cheaper than it was 10 years ago. If you have somebody with resistant hypertension, and before you order the vitamin D level, please order an aldosterone and renin. You may save life with this screening. I never heard of anybody saying, Dr. Ren, you saved my life by ordering this vitamin D level. Thank you very much. But people have said to me, hey, thanks for diagnosing that aldosterone disorder. It really made a difference in my outcomes and my blood pressure. So what are the two causes of primary aldosteronism? Well, 30% of the cases, you find a little fatty tumor in the adrenal glands. And in the rest of them is hyperplasia in both adrenals. And what we're trying to figure out is the aldosterone production has to be independent of renin. So the renin has to be suppressed and the aldosterone has to be elevated. Because if both of them are high, this is not primary aldosteronism. It might be secondary to a renal lesion or a renal secreting tumor or something else. So you have to have that in mind. There is only one thing that gives you a high aldo low renin. It's primary aldosteronism. Either you have a mass, or you have hyperplasia, you have an isolated hyperplasia in one of the adrenals, or you have a genetic mutation that is causing this problem. So sometimes we do CAT scans and on these people, and like I say, in 30% of them, you find a mass. And what you have to remember is the radiologist usually tells you how dense the mass is, right? So these benign tumors, these adenomas that produce aldosterone, 99.9% of them have low Hansfield units, which is the marker density on CTs. So, and they're not big. The average size about 1.5, 1.6 centimeters. So that's something that you have to kind of remember. But if you see a mass that it looks big, more than 3 centimeters, heterogeneous, and the Hansfield units are greater than 20 or 30, this could be a field, this could be cancer, you can have a problem now. So just whatever you look on imaging phenotype really makes a big difference. Okay, so back to this case, the 59-year-old with a history of stroke and a resistant hypertension. Look at that aldosterone level, 33. Anything above 10 in a good day is elevated. The plasma renin activity was suppressed. Anything below 1, it's definitely suppressed. So what do we do next? We do a confirmatory test, and usually we give salt to patients to see they suppress the aldosterone. Doesn't sound like a good idea, especially if this guy already had low potassium and already stroke out. So sometimes we short circuit these patients in cases and we go straight to imaging. So you can start a spiral to control the blood pressure, absolutely. But then you can do a non-contrast CT. You don't have to give contrast to these patients. The non-con CT is good enough to diagnose a mass in the adrenals or tell you either no mass or maybe just a little bit of hyperplasia in both. So this guy had no masses on the adrenal CT, but his screening was so positive and a history of resistant hypertension, hypokalemia, that we explained to him that we can do an adrenal vein sample and figure out which adrenal is causing the problem. And if he's willing, we can remove that adrenal gland and see if we told him there is a very good chance that we can control your blood pressure. I guarantee you that your potassium is going to be normal after the adrenalectomy, and then go from there. So we definitely did an adrenal vein sampling. The radiologist places catheters in the adrenal veins and gives you these ratios of aldosterone and cortisol, and then it tells you, okay, the aldosterone production is on this side or the left side, and then the surgeons remove the one that has the higher localization ratio. In this particular case, the right adrenal gland was the one that caused the problem. and he went through an spironolactone. And instead of taking all these meds, his blood pressure got very well controlled, and he's only on lisinopril. This is another case we saw in clinic. Similar presentation, but he was a very young guy with blood pressure definitely on the higher side, already on 2 good medications at a pretty good dosage, and the potassium was low, which is about 30% of people with hyperaldosteronism have hypokalemia. So a normal potassium wouldn't rule it out. But this was something that makes you go, what else could this guy have? Even though he doesn't meet the criteria yet for resistance because he's only on 2 meds, the fact that has this problem, it should prompt you to say, okay, this is not the normal. He might have a secondary cause. We need to rule out this stuff. And then obviously we did an autopsy reading with him in the morning and look at those levels. Anything above 10 is abnormal, and the reading was suppressed. Anything below 1 is abnormal. So what to do with this young guy? So he looked like a bookcase of hyperaldosteronism. So we really wanted to know if he had a mass in the adrenals or he had some sort of genetic mutation. So the mass was there, 1.6 centimeter mass on the left side, and it was a fatty mass. And so we, based on the guidance, you don't have to do any other tests. So go straight to an adrenalectomy. And we had the surgery, and the guy doesn't take any meds anymore. Case 4, we're almost there. 65-year-old male with angina and has a cardiac angiogram, and the cardiologist does this drive-by of shooting contrast on the renal arteries, and he notes that there was a 50% of stenosis of the right renal artery. He's on lisinopril and carvedilol. The blood pressure is systolic for somebody that age, and those cardiovascular risk is maybe a little high. His artery is already in the 6s. He has no proteinuria. He has normal GFR. So what is the next best step for this blood pressure, for these patients with blood pressure? What should we do? Should we leave him alone? Should we try to adjust some of these meds, or should we just add a new one? And in this case, these are the 4 options. Should we add a thiazide diuretic? And I think that would be my preferred option. Should we add an MR blocker? Well, the blood pressure is not that high. I think with a little bit of diuretic, you can get to that systolic below 130. Can you increase the dose of carvedilol? His heart rate is already in the 60s. So if you go any higher than that, you may end up causing bradycardia when people feel analogy. And this is the new non-steroidal mineralocortical receptor antagonist. This is not approved for this type of patient. It's only approved for patients with diabetes and high cardiovascular risk outcomes. But just to an aside note, the systolic blood pressure response to this phenylalanine is very poor. It's almost maybe less than 3 points on the systolic. So we're kind of disappointed that that's the case. So in that case, we just added a small dose of diuretic. We don't go after those lesions. One of the most often screening tools that we do in our practice is this one. The kidney ultrasound with renal artery Doppler is a good screening tool. It's a good triage tool to figure out where we are in terms of renal vascular disease. And one of the things that I pay attention to is this peak systolic velocity in the main renal artery. If it's greater than 200 centimeters per second, the probability that you're going to have a hemodynamically significant lesion is about 85% if you were to do an angiogram. So this is a great tool for us. Okay, so do we fix every single renal artery lesion? No, only if we kind of control the blood pressure medically, or we have patients that are worsening GFRs with time, and most likely is produced by these narrowing in the kidney vessels, or they have repeated pulmonary episodes, plasma episodes, and they get admitted to the hospital often. So we rarely go in there with catheters and mess around and put in stents. So in the last maybe 20 years, I've done it maybe 10 times only. So we definitely try to use this ACEi, so whatever we can they can tolerate, control the lipids, and in this case, diuretic was the best option for this individual. Case number 5, and I think this is the last case, and how we're doing in time. Actually, we're gonna have plenty of time for questions. So this is a 75-year-old man with a long history of hypertension, but otherwise healthy, and he comes to your clinic for routine follow-up. So the blood pressures are 152/65 on the right side. On the left arm is 150/55. I just put this over here. I know that most of you guys don't look into the pulse pressure, but his diastolic was a little bit on the low side. So his pulse pressure was about 95. What is the pulse pressure? The difference between the systolic and diastolic. What is the normal? I don't want my pulse pressure to be higher than 40, right? When he's above 80, we risk the cardiovascular events increase. His heart rate is 60, his BMI is below 30, he has no murmurs or exam, his lungs are clear, and he looks like fine on exam, no problem at all. His meds are chlorthalidone, lisinopril at a good doses, and his labs were unremarkable. And then, given his high pulse pressure, the thyroid disease was tested, and he has no history or regurgitation of coronary disease, and he doesn't drink alcohol. So he's 75 with a blood pressure that appears to be systolic, obviously above goal, but the diastolic is definitely on the low side. Is this bad for you? And do we have any options to treat this patient? So those are my 5 options: spironolactone, add an ENaC blocker, consider increasing the chlorthalidone, or start him on a low dose isosabine, or do nothing. So is there a J curve in hypertension, and do we have any data to prove it? And the answer is yes, we have some retrospective data. Do we have guidance on how to treat these patients? And the answer is no. So no one is going to tell you do these, do that, because there's not a lot of data, and we still we have these. Obviously, every time you see this patient over here, you decide, okay, if we drop the systolic and the diastolic drops further, is that bad for him? Or the other way around? Are we just choosing to protect the brain and the kidney at the expense of him having, her having a heart attack, even the diastolic blood pressure? And what is the data? The data is all retrospective, okay? And so we don't have a randomized clinical trial that follows patients who will tell us what the answer is. This is data from 2006 from this investigator, Messeroli, France Messeroli. This was a huge study looking at verapamil and I think it's trandolapril in the treatment of hypertensive patients with coronary disease. So this graphic on top is the systolic blood pressure, and on the left tells you the incidence of primary outcome, and the primary outcome being you die, you had MI but didn't kill you, or you had a stroke but they didn't kill you. What was the incidence of those outcomes if the systolic were to be from 130 up to 160? So you can see that the incidence went up when the systolic started to go up above maybe 150 to 160, and when it was too low, so spike. But J-curve might be there, but not as evident as you see here in the lower picture. When you see your diastolic dropping below 70, your incidence of primary outcome was up to 30%. And it's you saw the same thing with diastolic above 110, right? So this is concerning, right? So if your systolic blood pressure is below 70, your risk of cardiovascular outcomes goes up. Okay, I'll show you 2 other trials, and this is, like I said, people went retrospectively and figure out these data and find out the same thing. On this, for example, TNT trial, hypertension with heart disease, they found out if your blood pressure goes below 70, your diastolic your cardiovascular percentage event went up to the similar rate than the INVEST trial. So almost 25%. So it's definitely a J curve over there. It's not good to have diastolics below 70. He might tell you that, hey, you actually perfuse your coronary arteries through diastolic pressures, correct? So you might have disease there that will increase the risk of heart attacks. The risk of strokes, if anything, is not really increased with low diastolic blood pressures, is heart attacks. The risk of stroke is mainly associated with the systolic blood pressure. And then another thing that they found out that I think is quite interesting, and sometimes I think about it in some of those patients. So let's say you have a patient that has low diastolic blood pressure in the 60s, and they haven't had a revascularization process, meaning they haven't had bypass or they haven't had a cardiac cath and they found a lesion there and they had an angioplasty. So in those patients, if the diastolic, for example, were to be 55, but if you had bypass or other sources of revascularization like a stent, the risk is definitely half of the risk of the people that haven't had this procedure. So should we start screening every single one for this disease in somebody that has no chest pain at all, that they have no other symptoms? That's the question. So what to do with that particular patient? So most doctors out there would say do nothing because the risk is definitely there that you may end up causing a problem. But there is some data out there, very small trials showing that, for example, the use of long-acting nitrates might be beneficial in some of these patients. That you put them on a very low dose of nitrates, and then you lower the systolic, but the diastolic doesn't change. Okay, so you can argue that you can use those. So you have to have a frank discussion with your patient. Hey, this is abnormal. It might reflect that you have severe atherosclerosis. Maybe we definitely should consider getting an echo to make sure that there is no wall motion abnormality, that we need to do something else to find out if there is anything there that might be causing this problem. Make sure that you don't have aortic regurgitation, but that would explain the pulse pressure. With age, our diastolic blood pressure goes low, but not to this degree, okay? So if I were to have a young athlete with a blood pressure of 120 over 60, I would say we don't need to do anything. I think your risk only increases when the pulse pressure is elevated like this individual. So it's a tough case. Some people would say, okay, let's refer him to a cardiologist and see if we can definitely address some of these atherosclerotic disease. Does he have that in the heart? Does he have valvulopathy in the heart? How aggressive should be? And I usually have that discussion with that patient. Most doctors that I know would say do nothing besides controlling cholesterol and so forth, and maybe getting lots of blood pressures at home to make sure that the systolic is not truly 150 like it is in the office, and maybe it's 140 over 55 or 140 over 60 or below that, and then you leave them alone. Okay, so when to refer to a specialist or hospital. So there's doctors out there that are hypertensive specialists. You have to take a test. And then I think in the past, the former American Society of Hypertension would give you those tests and you renew that every 10 years. And I think now the American Heart Association also does those. So when to refer to one of those clinics or a nephrology clinic, or some people send these patients to the cardiologist as well. So when you have a young patient with hypertension and you think about a secondary hypertension cause, you should definitely refer those patients to, I favor, to us, because we have a little bit more experience with these patients, and remember that if you look into genetics, there is at least 5 monogenic causes of hypertension that deal with salt transport in the kidney, and we have genetic testing for all of them right now. Patients with sudden onset of or duration of hypertension, definitely those are candidates for us to see. Patients that are treatment resistant hypertension. We love to see those patients here. Or when somebody has been admitted to the hospital with hypertension emergency, those patients tend to have a high prevalence of secondary toxicities. Well, I hope that this was informative, and we can definitely be available for any questions you might have.
Thank you so much. That was amazing. Just want to thank you for being so generous with your time and your expertise here this morning.